Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral blocked ears, and we're just commencing with their left ear first, which is the worst ear out of the two. And you may have just noticed the entrance of the ear canal was quite inflamed, swollen, there's a bit of edema there. And that was in part because the patient's been rubbing their ear because their ear is blocked in an attempt to try and unblock it. But also, they have developed a reaction to hydrogen peroxide drops that they've been using to try and soften this skin plug, which, to be fair, has softened it. The last time the patient attended, they need to attend, I think, twice a year. The skin plug in their left ear is rock solid, and the hydrogen peroxide drops has softened it. And as a comparison, when we clean their right ear where they haven't used any drops, you'll see the difference in consistency. However, what the hydrogen peroxide drops has also done is made just the entrance of the ear slightly tender and inflamed. They've been using it for quite a while, these drops. They thought if they used the drops, then they may not need to have their ears professionally cleaned. The drops will remove the wax for them. But unfortunately, that's not the case. Once you've got a substantial buildup of earwax, any form of drops that you'll use will either just soften the wax or break it up into smaller pieces, but it will still remain in the ear. So they put themselves in, and the reason why this patient has developed a reaction using hydrogen peroxide based drops is because our ear is slightly acidic in nature, and the acidity helps to repel insects, believe it or not, and also to inhibit harmful bacteria and fungi growth. When you use hydrogen peroxide based drops, which is alkaline in pH, it neutralizes the ear, so the ear becomes less acidic and more neutral, and sometimes even slightly alkaline. And that then can cause a reaction at the skin, on the skin flora. So the skin that lines the ear canal, it's got its own ecosystem there, where you've actually got healthy bacteria and healthy fungi protecting the skin and from more harmful versions and variants. But once you've neutralized the skin flora and it's less acidic, then more harmful bacteria and fungi can colonize on the skin flora and reproduce and cause a bit of an infection. And so deeper in the ear, the patient's ear is not too bad. You can see the ear canal, it's got a nice fleshy appearance. So it's just the entrance. Now, this plug is quite a tricky one to remove. Would we classify it as a keratosis obturans? I would say no. If you watched my video yesterday, I presented with a case of keratosis obturans, which is a buildup of dead skin, typically more medial. That's why I would say this is probably not keratosis obturans. This is more lateral or the midsection. And the patient wasn't experiencing any pain. The hallmark of keratosis obturans, there's 4 different grades, but all of them there's some level of pain. So this patient, they just have a lot of dry skin, predominantly at the entrance of the ear and the outer third of the ear canal. And you'll see as we go in and out, more so on the right side, you'll just see the dry skin flakes this patient's got at the entrance of the ear. And they just fall and they don't migrate, and they collect. So I just trying to get in and behind this. It is a challenging one because of how narrow the ear is. And with the hook, because the wax and the skin plug is a bit softened, it just dissected through it as opposed to bringing it up. I'm saying that I did get a nice sizable piece out here. With the Jobson horn, it's difficult to use it in this particular case. I think I did attempt to, but more left to right, if memory serves me correct, or is that the right here? We shall see. And the reason for that is the Jobson horn, the width of it is about 2.5 up to 3 mil. There's just different types available. But the ear canal width in this patient's ear is below that, so it's a squeeze to get in. You can get it in probably more vertical, so against the left and right side of the ear canal walls, but not over the top, which is or at the bottom, which is ideally what we want to do here. So we are making progress. We're bringing this to the entrance. So this is on the left-hand side there, the flesh there, that's the first bend. So we're about 0.5 centimetre now from the entrance of the ear canal. So we have brought it forwards. And the secret is it's just detach that white matrix of skin. You can see that's wrapped around this plug, because that is still also attached to the ear canal wall. Think about that envelope skin, that white skin that you saw, that glossy peripheral matrix of dead skin, as double-sided sticky tape. Not only does it adhere itself to the skin plug, but also to the canal wall. And now we've managed to get the hook in just a bit further over the top, and we've just brought that out. And if you wait till the end of the video, you'll see a still image of this. So we're going into the ear, quite a narrow ear, hairy ear as well at the entrance. And that's the patient's eardrum. They've got quite an inclined ear canal as well. So all of our ear canals, there is an upward slope, and on average 32 degrees, but there's a big range in that. However, I would say this patient's ear canal angles upwards are significantly more than 32 degrees, probably 40, 42. So when we go into the ear, you got to be careful. We just don't pop into the ear. You've got to angle the endoscope upwards. You almost have to cox your wrist backwards. So you can see how narrow that ear is. You can see all those hairs there, going through the hairs, angling the endoscope upwards to view the eardrum. And the left is clear. Now this is the right. You can see there's a lot more dry skin here, like an eczema at the entrance. This is a really dry plug of skin, and that's why it's reflective. It's just shining back at us. So I've just started off with the hook, trying to get in behind, trying to break this up. So recommended the patient in their left ear just to use some acetic acid spray, because they've been using the hydrogen peroxide drops. The pH levels neutralized, so we want to re-acidify the ear, and that's what acetic acid is. It's essentially a white vinegar, and you can get it in special formats for the ear, so a spray applicator, and the acidity in the acetic acid will just re-acidify the ear, make it more acidic, so to prevent harmful growth of bacteria and fungi in the ear. And on this outside part of this ear, they've just recommended some over-the-counter hydrocortisone cream, just at the entrance, not into the ear, just on the cavern concha region. The inside of the ear is not bad on this side, it's just more on the outer, the bowl of the ear there, you can see. So just put some drops in here just to lubricate the canal wall, because this skin is quite tightly adhered. Just bringing it forwards. When you've got a dry plug of skin, it's sometimes harder to get a suction grip because the surface of the plug is quite rough. It's like sandpaper. So it's harder to get a suction grip. And in addition, when it's rough like that, as you're bringing it forwards, the surface of the skin plug, it's abrasing against the canal wall. So it can be a bit uncomfortable for the patient. It's just essentially like having sandpaper in your ear and someone's rubbing it. So the oil just helps to lubricate it all. So brought it near the entrance. I'm going to use the hook. Now the problem with the hook here, I couldn't get a purchase in it. I'm trying to almost stab it in. I want the tip of the hook to get into the core, but it just pushed it down. It didn't actually penetrate in. So I'm just lifting it back up again off the floor of the canal wall. And I'm just slowly trying to wriggle it through. And I'm just kissing the surface. If I apply too much pressure with the sucker, because of the surface, it's quite rough, you're just going to be pushing it further in. So we're almost hovering over and making the most minimal amount of contact with the surface of the skin plug. And the secret is not to come away too quickly with the suction probe. It's always a tendency, myself included, once you've got once you feel you've got a good suction grip, you just come away and you think the plug's going to come with it. And you sometimes just got to slow it down, bring the suction probe out slowly but surely, because if you come away too quickly, you lose the suction grip. So almost teasing this through. The patient could feel this. It wasn't uncomfortable, but they did say they could feel it coming out because of the size of the plug in comparison to the width and the aperture of the ear canal. The plug's wide and it's rough around the edge. And I think now I'm going to use the hook. So we brought it forwards enough so I can get the hook right behind. So instead of penetrating into the core, I can get in and behind this now. So I'm just using the roof of the ear canal as a guide. In and behind, prizing it out. Again, there's a few hairs in there. There's a bit of dead skin just at the roof, so we're just going to remove that. tug that away. It's just attached on the back canal wall. So there we are. I've just managed to loosen that and bringing it out. So the patient has got mild otitis externa. There's the eardrum. Sorry, it's just a bit, the hairs that kind of obscure the view slightly. So that's the plug from, this is the big plug from their left ear, and this is the front and back. So that's the back and that's the front. So there's the same plug there, but it just gives you a good perspective of the size and the difference in colour. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.